Hi, everyone. Welcome from me as well. Thank you for sticking it out. And we are hoping to delight you with some new information today and let you finish your conference with a nice send-off. So our topic today is transitional foods, updates on their behavior, use, and benefits in both the adult and pediatric population. So I am going to first start out with some disclosures. Included in this presentation are findings from research that was partially funded by Taste for Life, which is owned by me, myself, and I. And it is a mission-based company focused on research, innovation, and education in transitional foods, and has created savories, dissolvable snacks, and dips, which are discussed in this presentation. Dr. Samantha Shune has an ongoing volunteer advisory relationship with Taste for Life. And if you have any more questions on these disclosures, please feel free to contact me at my email address. So I am going to give you a little insight into our areas of interest and the genesis of our collaboration in this area. I am a prosthodontist and trained French culinary chef that started to see an issue that happened with my patients that had dysphagia. And I learned that dentists don't know much about dysphagia. I come at the problems from a mastication approach, and that's the training of a prosthodontist, is to optimize mastication through full mouth reconstruction. And I realized that if I didn't understand dysphagia, then I wasn't fully understanding the goals of my treatment in some head and neck cancer patients, which are part of my practice. Neither are my patients fully understanding the goals of treatment and coming to see me. So enter Samantha Shune. I was at an OSHA conference, actually, and I was doing a dysphagia survey and started talking with her about food enjoyment. And our mutual interests were just readily apparent. And I'm actually really delighted to be speaking with her today on transitional foods. She is really well known in the area of optimizing the dining experience for people with dysphagia. And today, she's going to present a comprehensive look at testing of transitional foods. She's also going to talk about the oral environment research and leave you with the most important piece, basically a how-to guide or implementation guide for use in your practice. I am going to come at it from what I'm good at, which is food sensory science, and talk a little bit about the definition of transitional foods, the advantages of transitional foods for your patients, and the value of finger foods and snacking, of which transitional foods fit within. I'm gonna start you off with it's now 4 o'clock and we're ready for snack time ourselves, I'm thinking. Dr. B.J. Miller, he did a TED Talk, and it was a great TED Talk. I recommend it for you. And he is a physician. Let me just tell you what he wrote, what he said. Probably the most poignant room in the Zen Hospice guest house is our kitchen, which is a little strange when you realize that so many of our residents can eat very little, if anything at all. But we realize we are providing sustenance on several levels. Smell, a symbolic plane. Seriously, with all the heavy-duty stuff happening under our roof, one of the most tried and true interventions we know of is to bake cookies. As long as we have our senses, we have at least the possibility of accessing what makes us feel human, connected. So, Dr. Miller was describing the particular sense of smell with the cookies to conjure up those happy memories. And I'm going to talk about sensorial delight in the vein of transitional foods, because transitional foods give a person a food they can hold on to, crunch into, and provide a very different visual connection as compared to puree or thickened liquids. At ASHA last year, someone said to me that transitional foods are perfect for pleasure feedings. And I'm sure everyone uses that terminology. That was new to me. And as a dentist, you know, and culinary chef entering the world of SLPs, the term pleasure feedings made me realize how changed the dining experience can be with dysphagia and the importance of these primal sensorial delights that he talked about. So let me just start by saying, what are transitional foods? They are foods that start as one texture but change into another with moisture, which is water or saliva, or temperature change. Right here on the left, you'll see the IDDSI pyramids that I'm sure everybody is aware of. And on the left is the gray bar, which is transitional foods. And you can see how that gray bar extends from 7 all the way to the beginning of 4 or just the end of 5. And that is just showing the transitional nature, how it changes state in the mouth. The other criteria is no biting and minimal chewing is required. And simple tongue pressure can break the transitional food down. No size restriction exists, and the degree of texture transition is variable, but must at a minimum pass the fork pressure test. These last 2 descriptors are things that Dr. Shune is going to describe in more detail for you guys. So, if we perceive and evaluate our food through engagement of the senses, all of us do, I'm going to talk to you about dysphagia and how this might change for someone with dysphagia. The drivers are still the same. You know, maybe with age, the senses get dulled a little bit. ALS, for example, the senses stay the same. There is no reduction in the sensorial aptitude of someone with ALS. But the driver, say the #1 driver of why we eat, all of us around the world, is the appearance of the food. That is the #1 driver for why we put it in our mouth. It's the color, the shape, the volume, what we anticipate. That's vision. When it comes to taste, I asked Dr. Lisa Dweezer, a specialist in the area of food sensory science, in people with dysphagia, why do we lose flavor when we puree our foods? And she shared that when you puree foods, the volatile compounds which make up part of the flavor of foods are released in the air when blending. They're released in the pureeing process. But with a solid food, the cell walls of that food are broken in the mouth, and the volatile compounds are released in the mouth, and we perceive them through olfaction and through taste. So the typical problem with a texture modified diet is that compensation can be made with taste by like opening up more flavor profiles in the food. The visual appearance, as you know, with puree can be modified in minced moist foods, but the areas of food sensory deficit is clearly in sound and touch. Using a utensil like fork, knife, spoon is indirect touch, which is not the same thing as picking it up with your fingers. I'll talk more about this later. And of course, puree textures have no auditory component at all. So I'm going to share with you that with taste and smell, sight and hearing perception diminishing with age, transitional foods can re-engage the senses and make food consumption more pleasurable, because crunchy, meltable textures can engage sound and typically are finger foods that are touched. So an area of food science is called texture studies. And I don't know if you realized this, because I certainly didn't know that there's an actual journal of texture studies. And I came to know someone named Dr. Carolyn Ross. And she did a study, which I think you'll all find really interesting. And it talks about the pediatric side of texture and texture aversions. Oftentimes occur because of difficulty eating something or trauma or a bad experience. It's actually, you probably know more about texture aversion than I do, so I'm preaching to the choir. But what she did was she did a study on Down syndrome that was recently published. And she looked at young Down syndrome children, ages 11 to 58 months, and there was about 157. What she did was she did an online questionnaire for the parents, where she did look at 26 different texture categories of foods. And she wanted to find out from the parents, in these texture categories of foods, which ones are difficult textures and which ones are easy textures for your child. And the difficult textures were the chewy and firm, and the easy textures were creamy, crispy, crunchy, dissolvable, mushy, puree, smooth, and soft. Well, guess what? The crispy, crunchy, dissolvable fits into transitional foods. So I'm going to take a little deeper dive into the categories of transitional state foods. Because when I said crispy, crunchy, I meant the solid foam side, and dissolvable speaks to the solid foam and the solid gel. So let me just go further. A solid gel transitional state food is usually a food that is more dependent on temperature than moisture added to it to dissolve it. So ice chips, magic cup, ice cream, Japanese dysphagia training jelly are all good examples of this. Now, on the other hand, solid foams are stable at room temperature and tend to remain so with increased temperature, but the transition happens more with moisture than it does with temperature. So they're typically known as crunchy dissolvable or soft dissolvable foods. And you know, the examples here are Savory's crackers, which are the ones that I mentioned earlier in the disclosure, baby mums, shrimp chips, Cheeto puffs, Gerber puffs, and wafer cookies and shortbread. I would say not all shortbread, but the softer shortbreads. But I wanted to share with you that transitional foods, I like this term because it's not just about the physical properties that I just mentioned. It also has a secondary meaning to me, and it's more of a therapeutic meaning. I think it can help people in a rehabilitative sense as they transition from one texture to another, or it can provide training and experiential learning as a child can transition from tube feeding to a solid food diet. And if we look at the history of transitional foods, it has been used in the pediatric population the majority of the time for less developed chewing motor systems. But adults can face similar issues related to chewing, right? With multiple missing teeth in their mouth or developing dysphagia. And so I really feel that transitional foods can meet their needs as well. But the deal is, adults don't want to eat baby mums or Gerber puffs. So this push has led to more transitional foods in the adult category and increasing our understanding of its use in the adult category. So today we're going to focus on the solid foam category of transitional foods. And all of these foods typically start at a regular 7, but what they transition to depends on each type of product. And Dr. Shune's going to talk more about this. Some can transition to level 6, to level 5, or even 4. And the bottom line is whatever it dissolves to, we have to look at it as an extra option for a diet that, let's just say the diet is a level 6 diet. What we're trying to do is explore options in transitional foods that fit within their diet. And this requires an understanding of transitional foods and a proper testing of those transitional foods in that particular patient. So let's just talk more. I'm just going to share that we are going to talk more about this, but I'm going to really kind of introduce transitional foods to you before we dive deep into their behaviors and testing methods. So the advantages of transitional foods are actually 3-pronged. And I wanted to share with you that this presentation comes with a great handout. It's not, the PowerPoint slides, it is really like a handout that you can keep at your desk that has all these details in them and all the pertinent stuff that is kind of meant to be more of a go-to guide for you. So please, please download that and hold on to that for informational resource. It has all the reference articles as well, so you can have that as a resource. So anyway, let's talk first about the psychosocial elements. So we have here for kids and adults, and there is definitely crossover in the psychosocial aspect. We can look at chewing training as an ability to develop that person's, that child's ability to eat more solid textures, starting with a transitional food after a puree diet. Self-feeding is really important for empowerment, and frankly, transitional foods are fun. And it fits the eating behavior of slow eaters, so they can graze and eat on their own. Very important for kids. It's shareable and social. You know, a mom said to me, I want the snacks to be shareable snacks in the playground so that my child with special needs and special textural needs can share a food with her friends and not feel like it isn't something they would be interested in eating. So that's really an important property, not only for kids, but also for adults. Palate burnout is a real problem with puree diets and modified texture diets. It can jazz up the palate. It can create a break from the monotony of a certain texture if used appropriately and chosen by the SLP to include it. Familiarity is really important. Shapes provide familiarity to food. If the food resembles food they used to enjoy, it can provide positive food memory. Liberalizes a diet. Of course, eating independence is an empowerment for the elderly as well as mealtime dignity and socialization. So this is a video by Nancy Hoke. It's a short little snippet. She is an RN that's really well known in the ALS circles in Portland, Oregon, and she's going to talk a little bit about her impression of transitional foods in her population.
This does normalize life for our ALS patients because it allows them to eat even a little bit. We call that recreational PO intake. They just the ability to have something to swallow and be with their family and share food.
So she says it in a nutshell better than I ever could. So she's a delightful person that has taught me a lot, actually. I want to talk a little bit about sarcopenia. It's a big concern in the geriatric population and contributes to more severe outcomes in many different aspects. Dysphagia in this same population through a modified diet can worsen sarcopenia. Why? Because a typical puree diet contains almost 50% less protein than a regular diet. So purees need to be fortified, right? We need to do what we can to improve the protein intake. And a similar discussion is happening with adult snack food, and in particular for today, transitional foods. But the challenge that I see with transitional foods is largely because of how it's made and how much nutrient density you can pack into a foam. And I've spent a lot of time learning how to fortify transitional foods with plant-based protein and maximizing healthy fats within a foam dissolvable matrix. It is possible, folks, that you can do it, but we know that this particular snack of transitional foods for elderly can become more nutrient dense and therefore more valuable to them. I'm going to share with you what happened early on in my investigations. What I did was I went to nursing homes and I evaluated snack carts, and I talked to different dietitians about the snack cart. Here is an example of a snack cart that comes from a typical long-term care company of homes here in the Pacific Northwest. And you can see how they broke down the foods on the top. You can see it was mechanical soft, dysphagia mechanical puree, diabetic mechanical soft, and diabetic puree. And really what they did was they have the snacks on the left, and they indicating which snacks particular people, based on their food texture modifications and their dietary modifications, can have, right? But what we can, it is only the snacks at the bottom that are highlighted green that are available to everyone. But when we look closely at those snacks at the bottom, we can see that they are low in nutritional value, except the supplement and perhaps the yogurt. But what they are all, they all have high levels of sugar. David Bain presented a poster today looking at snack foods in a nursing home, and we can share that reference for you. He found that calorie and protein enhanced snacks, which included transitional snacks, fit the 4 categories mentioned on top there, improve the nutritional profile of snacks for the residents. And so basically this changed our impression of the value of snacks as becoming key components of the overall nutritional plan. One of the things for sure transitional foods can offer your patients and the caregivers is simplicity. Essentially, it can increase choices in level 6, 5, and potentially 4 in an on-the-go kind of convenient snack form, which you can't get otherwise. So most of the transitional foods are shelf stable, the solid foams, again, that I'm talking about. So here I'm just showing you a kind of a pyramid of transitional foods and just sharing with you that transitional foods are defined for the texture modified diet, right? They're the meltable solids, but they fit into the category of finger foods, and then more broadly into snack foods. And clearly not all snack foods are transitional foods, but what we can see here is that transitional foods provide an opportunity for someone on a texture modified diet to eat a food that not only resembles a snack food, it is a snack food. And there are a lot of advantages to snacking. In adults, if we can change the number of times they eat from 3 times a day to 5 to 6 times per day, we can improve overall daily consumption of food, increase body weight, and decrease length of stay in hospitals. Why? Because we are meeting their new eating behavior challenges with an opportunity to eat slowly, eat more frequently, and graze. So the other thing is it can support eating independence. These are some great studies which are referenced in your handout as well. So I take for you an example of a traditional meal plan. And this was offered to the ALS Association as like, this is a typical meal plan for someone on a modified diet with a heavier focus here on getting the calories from breakfast, lunch, and dinner. And there's a snack offering as well. But you can see that this is a traditional approach to eating. What I'm going to suggest to you is if we did an updated meal plan based on that research data of doing more 5 to 6 smaller meals a day, we can take away the burden of eating a big breakfast, perhaps for someone with ALS or someone who had a really hard night and is fatigued. And we just put more of an emphasis on having smaller mini meals or interim meals throughout the days called snacks. And we can take those snacks and not have them be empty calories, but we can actually power them up. And transitional foods can fit into that snacking regimen. So as I said before, transitional foods are also finger foods. And touching our food basically with our fingers instead of the fork and knife can enhance the sensory experience of eating. The brain thinks it's tastier and more satisfying before it actually reaches the mouth. And when they looked at people with high self-control, these are people that are really watching their diet, they will eat more if they eat with their fingers. So we can, there's several studies looking at dementia, and they're showing that we can increase nutritional intake and enhance independence and well-being for adults with cognitive impairment in long-term care settings with finger foods. So there is a lot of power to finger foods that honestly is still to be explored. So in the last slide, these are the last two slides that I'm going to give you. I'm going to share a little bit about the dentistry side of me to talk a little bit about cognitive benefit of mastication. Why am I talking about mastication? Well, when you put a transitional food in your mouth, whether you need to chew it or not, it is an automatic impulse for your jaw to start moving up and down. And there is benefit to that up-down movement of your jaw. And we are learning new things about the cognitive benefits of mastication in animal studies and human studies. And basically, when you impair mastication, like in mouse models where they removed all their teeth, and it affects their learning ability and memory. And we also showed that soft diet in animals reduces neurogenesis in certain parts of the brain, like the hippocampus. So in human studies in young populations, it shows that mastication can improve cerebral blood flow and cognitive testing. So this is really something that I think we should study more in the basis of transitional foods in a texture modified diet. So I'm going to end my section with this really wonderful image, evocative picture that was presented on this New York Times article that I highly recommend that you read. Elizabeth Jameson, she has progressive MS, and she's an author and artist. And the title of her story was "I Never Stopped Lusting for a Good Bite." And the emotional language that she used and the imagery is so clear that she describes her changed relationship with eating when she developed dysphagia. And much of what she writes about is the craving for crunchy foods and the mutual frustrations with being fed with her and her caregiver. And when I read this, I realized the potential of transitional foods to change the eating experience for people with dysphagia for the better. So I'm excited to now share with you or pass the baton to Samantha to talk about implementation and current recommendations for you.
Thank you, Reva. Let me switch over to my screen now. So we are going to shift gears a little bit and talk more about the implementation of transitional foods into clinical practices. In particular, I'm going to target what we currently know based on the literature and how that information can ultimately help guide our practices. So I know we've talked a lot about IDDSI at this point, the International Dysphagia Diet Standardization Initiative. But for those of you that might be a little less familiar with IDDSI, each level of liquid and food that Reva introduced previously has a specific testing method or sometimes multiple methods associated with it. Now, transitional foods actually pose a bit greater difficulty as they start one texture and then end as another. And ultimately, what we are likely most interested in when discussing patient safety is what the product will transition to after being exposed to body temperature and moisture in the mouth. So to simulate this process, the IDDSI food testing method document outlines the procedure for the fork pressure test. And first, what you're going to do is you're going to take a 1.5 by 1.5 centimeter sample of the product, and you're going to expose that to 1 milliliter of water and then wait 1 minute. As a quick clinical misconception aside, this is not the size that the food item needs to be. This is the size used for testing the product. The size that the food needs to be is what level of the food pyramid you're targeting. So the 1.5 by 1.5 centimeter is simply for the standardization of testing. So once this product has sat in that kind of water bath for a minute, you would complete the IDDSI fork pressure test, in which you actually press down on the sample with a fork to the point that your thumbnail blanches white. And a transitional food is then defined as one in which, after moisture or temperature has been applied, the sample can be easily deformed and does not recover its shape when the force is lifted. So for example, here, the sample is a transitional food texture if, after removing the fork pressure, the sample has been squashed or disintegrated and no longer looks like its original state, or it has melted significantly, because we talk about those two types of transitional foods. And so if it's melted significantly and no longer looks like its original state. So for example, ice chips or ice cream. Significantly though, we actually do not know what the relationship is between that IDDSI benchtop testing and actual mouth behaviors. So for example, in IDDSI benchtop testing, we're using water, which we know has a pH level of around 6.5 to 8.5. On the other hand, when we're actually consuming something orally, we know that saliva is a biofluid. It initiates carbohydrate digestion, the mucins provide slippery bolus coating, and the pH tends to be more of a 6 to 7. There's no temperature defined for the IDDSI testing in terms of what water temperature we should use, whereas we know that the oral cavity has a very specific temperature range. The IDDSI testing method has us put that sample in a water bath for 1 minute, but we certainly know that oral transit times in the oral cavity widely vary, and they can range anywhere from 1 to nearly 13 seconds in a healthy adult. And finally, in the IDDSI benchtop testing, we are specifically using 1 milliliter of water, whereas in the oral cavity, this is very variable. We know that secretion rate varies across individuals. This can range anywhere from 0.33 to 2.3 milliliters per minute in, again, those healthy individuals. We also know that not all foods may behave the same, despite being classified broadly as a transitional type food. So if we go again to the pediatric population for a moment, the American Academy of Pediatrics recommends that young children start with finger foods that are easy to swallow, that are cut into small pieces, and that are soft. And those actually match a lot of the criteria we also use for older adults and adults with dysphagia. This is the results from a nice article by Awadallah and colleagues, and they actually tested 9 products marketed as first finger foods. They tested the majority of them fresh, as well as being left out of packaging or exposed to air for an hour or more. If any of you have children or work with children, you know that commonly foods get opened up and left on the counter for a while. And so this study actually used adult testers, where they had the adults put these products in their mouth, not using teeth, so kind of manipulating it in the mouth without using teeth, and then rated the products on time taken for the product to become soft and break up, the time for each product to dissolve completely or become small enough that it had to be swallowed, and any tester comments related to product safety. The most commonly failed criteria was softness, with actually only 2 of these products, or really it was 2 flavors of the same product that are commercially available, meeting that softness criteria. Now, while many of these findings were based on more subjective measures, and the study was certainly not intended to address the safety needs of individuals with dysphagia, what we can take away from this is that not all supposed transitional products behave the same way, particularly in the oral cavity. So it's clear that as speech-language pathologists, a number of questions remain regarding the clinical implementation of transitional state foods. First of all transitional foods indeed created equal? And what is captured or perhaps not captured in our currently available testing methods? So I'm going to spend a few minutes now discussing a recent study that we published attempting to address those clinically relevant questions. The study specifically addressed the following. So how is the dissolution of solid foams influenced by different in-mouth conditions? So differences in time in mouth, differences in pressure, and differences in saliva. And secondly, do different transitional foods perform differently based on the IDDSI transitional food test? So we had individuals who were 50 years of age or older with or without xerostomia and with or without dysphagia. Each participant was actually trained on 17 kilopascals of tongue pressure using an IOP device. And we selected 17 kilopascals of tongue pressure because in the IDDSI BENCHOP testing, that's the approximate pressure we're giving with the fork. So the thumbnail blanching to white is about 17 kilopascals of pressure. Each participant was then presented with 4 de-identified samples of each snack that we used. They put the sample in their mouth, and I'll talk about the different conditions that happened in the mouth, and then they spit the product out and we analyzed it. So the different foods that were tested were the Savory's cracker. We also had the Savory's cracker dip, given that the cracker is actually intended to be served with dip in order to meet nutritional requirements. We did test the cracker both with and without dip. We also used shrimp chips, baby mums, and the eat bar. So all commercially available transitional type snack foods. Now for each of those 5 samples, the participants would put it in their mouth for 5 seconds and use no tongue pressure, put it in their mouth for 5 seconds with tongue pressure, put it in their mouth for 12 seconds with tongue pressure, and then put it in their mouth for 12 seconds with pulsing tongue pressure. So actually moving their tongue up and down more in kind of like a masticatory type pattern. Our participants, we ultimately had 30 adults in the study, 17 were female, mean age of about 67 years. A third of the sample did self-report dry mouth, and just under 30% of the sample self-reported the presence of dysphagia. So I'm going to present a few of the results from that study. And when I refer to dissolution here, I mean the presence of a positive fork pressure test, or a fork pressure test that did confirm that the product met the definition of a transitional state food based on IDDSI testing. So the dissolution rates at 5 seconds and 12 seconds with and without tongue pressure, what we start to see here are that there are differences across the products, as well as for some of the products, there are differences across the different oral conditions that they were introduced to. Specifically, significant differences in dissolution rates did emerge for all pairwise comparisons, except when comparing the Savory's cracker to the Savory's cracker and dip, and when comparing the shrimp chip to the eat bar. So again, Savory's cracker versus shrimp chip was different, Savory's cracker versus baby mum, Savory's cracker versus the eat bar, shrimp chip versus baby mum, and baby mum versus the eat bar, all did show differences in their dissolution. Results comparing dissolution rates between individuals with dry mouth and non-dry mouth across all snacks at 5 seconds showed a trend for improved dissolution among those individuals with non-dry mouth, although this difference was not seen by 12 seconds. So it was at 5 seconds when we had them spit the product out, there was differences in dissolution, but when they had it in their mouth for 12 seconds, we no longer saw that difference. And then here is what that looks like, dissolution for individuals with dry mouth, specifically at 5 seconds with and without tongue pressure. And we're seeing those differences across products. We did also look at the individuals with dysphagia, and I'll pop that information up here. And we didn't actually see any differences, any significant differences between the individuals with self-reported dysphagia or without self-reported dysphagia. But here's the dissolution for individuals specifically with dysphagia at 5 seconds with and without tongue pressure across the different products. And so while we didn't see those differences in dissolution between individuals with and without dysphagia, we do start to see differences for the individuals with dysphagia in how those different products are performing in the oral cavity. There were also generally higher odds of benchtop dissolution for the Savory's cracker, and dip, and the Eat Bar as compared to the shrimp chip and baby mum mum. So this was following standard benchtop IDDSI testing preparation. So the 1.5 by 1.5 centimeter product sitting in the liquid bath, the water bath for 1 minute, and then doing the fork pressure test. Interestingly or notably, the Savory's crackers and the Eat Bar are two products that were really designed with individuals with dysphagia in mind, as compared to something like the baby mum mum, which is developed more to be like an introduction to food or a teether type product. So it's clear from this initial study that not all self-described transitional state foods will indeed act as expected in the oral cavity for every patient to the same degree. The increased dissolution rate using the standard IDDSI preparation procedures as compared to the intraoral preparation procedures does suggest that using the standard IDDSI protocol alone may not actually accurately represent a given individual's performance with a particular product. So these findings suggest that in determining the clinical utility of any given food, we likely need to consider the post-oral processing consistency, which is ultimately what that individual will be swallowing. Thus, even though a transitional food may start at a level 7, what is most relevant is what it transitions to for that individual in that individual's oral cavity in order to understand what patients can include in their diets safely. And so, first take-home point is we do need to assess dissolution, or we need to assess the behavior of those products on an individual basis due to patient-specific oral conditions. So what are the next steps? Where do we move forward from here? And there was a recent expert review that was published that did reveal a number of recommendations for the improvement of texture-modified foods. And this work was really aimed at individuals in care facilities, but I think it's most definitely applicable across the lifespan. So first, specifically made nutritionally enhanced texture-modified foods are needed, and they need to be enhanced with energy and protein-dense ingredients. As Reva mentioned earlier, we know that puree consistency tends to be very nutrient poor. We need to be offering a variety of options, flavors, optimal texture, different thickness ranges, and increased food attractiveness. We need to increase the diversity and offer a range of alternative meal choices and protein and energy dense in between meal snacks. So not be so committed to those 3 meals a day, and that's how an individual gets all their nutritional intake. And we also need to provide tailored support. So for example, more time to eat, a quiet environment, finger foods. And so I think transitional foods really check off the boxes for a lot of these recommendations that were made by this expert panel. So bear with me for a moment as I'm going to start a bit narrow and move wider. And I'm just going to give you a few additional research bites, really intended to be small little bites. I'm happy to talk more about any of these studies later or offline. So first of all, I want to talk about the important role of self-feeding. Self-feeding is a crucial part of the eating process. We want to promote self-feeding, hence that finger food recommendation that was made by the expert panel. And increased self-feeding can be accomplished through transitional foods where we're offering a safer finger food option. And so in some of the previous work that was completed in my lab, we explored the role of arm proprioception, or sensation from the arm during feeding, on other eating and swallowing related actions. In particular, we found that adults begin to actually open their mouth sooner when they have that proprioceptive information as compared to when they do not, such as when they're being fed by someone else, which often happens with our pureed consistencies. Further, and really interestingly, older adults actually begin this movement earlier than younger adults do. And so while these studies were specifically performed in the adult population, the results do mirror research that has been completed in infants and children, as well as in utero, supporting this really complex but tightly interwoven relationship between hand-arm movements and mouth movements, particularly during eating-related tasks. So this is something that we want to be maximizing and encouraging that self-feeding when possible. Another line of work that we have completed has examined the role of visual models or behavioral mimicry in eating and drinking. So among healthy younger and older adults, we found that observing another person drinking, so even during an unrelated, completely non-eating task, actually promotes increased drinking behaviors. So we're currently in the process of writing up results from a similar study that we completed in the nursing home setting, in which we found that eating while having someone else that was eating the same meal did lead to increased intake among individuals with dementia. Now, while family members or caregivers may be less likely to consume texture modified foods, transitional foods can really offer a safe for all option that can further promote increased intake by having all individuals being able to snack on the same product. Okay, I promised you I'm gonna start narrow and move more broadly. So moving even more broadly, I also did want to emphasize the important role that in-between meal snacks really play for many individuals with dysphagia. So we did recently complete a study exploring snacking habits and patterns among individuals in care facilities, and a majority of the residents agreed that snacks are a valuable part of the larger nutritional picture. They also emphasize the intricate relationship between food and socialization. So for example, anytime anyone serves food without socialization attached to it, they do not have an understanding of food. They just don't, because that is equal to or more than, you know, the food itself. Or I look forward to snacking, and it's generally associated with happy times. Snacks are very valuable. It's not just the nutrition that you get, it helps the whole body do what you need to do. I consider snacks a part of the daytime eating ritual. Yes, and Catherine, I see your message there. I'll get back to that in 1 second. And then I think that snacking is really good and good for a person. Snacking can be very positive and should be looked at in a positive way. And so again, as we consider individuals with dysphagia who may require a texture modified diet, we must prioritize opportunities for increased, easily accessible in-between meal snacks, including snacks that promote participation socially with others. And so there was a question about the individuals with dementia who increased their intake in the presence of others eating. That's a paper we're currently writing up, but we did present it just a few months ago at the Dysphagia Research Society. And so if you want to shoot me an email, I am more than happy to send that poster to you. So it's first initial and last name shune@uoregon.edu, and I'd be happy to share that. Okay, so finally, biggest picture, I wanted to end with one final reminder, and then we'll talk about some implementation strategies. Mealtime and eating success really rely on individualization and socialization. It's not a one-size-fits-all approach, and I think that's where we sometimes get into trouble in dysphagia management, is we try and say, if I see X, then I do Y. But really, one individual with dysphagia is one individual with dysphagia. And so in order to maximize health and quality of life outcomes, we must constantly challenge ourselves to find ways to improve the food we offer and context within which that food is ultimately offered. So what can clinicians do now? First, I think as SLPs, we must create multidisciplinary teams. This is not something that we can be doing in our individual silos. We need to work with dietitians and other healthcare providers. Remember, eating and meal times are related to nutrition and quality of life. And that should be of the utmost importance to all the healthcare providers that are part of the individual patient's team. We want to make sure we're exploring opportunities for increased safe snacking. Yeah, let me go back for 1 second. And so it's increasing those opportunities to eat throughout the day, but making sure that we're providing options for them to be snacking safely, that they have the variety to be able to be snacking safely. And this is really where the potential value of transitional foods come in. So it provides kind of that safe for all or safe for most option. It can fill a gap in IDDSI level 5 and 6 categories. So often we think, you know, regular foods, oh, texture modified, that means puree. What's kind of in between there that we have available to us? It offers increased variety and option. It provides an appropriate snacking option. It also can provide a therapeutic role in diet advancement. So it's a way that someone can actually work on mastication with a product in their mouth that would be safe for them to swallow. Finally, it also calls for us to reconsider our assessment protocols. So how do we actually define safety? How do we define quality of life? How are we taking those variables into consideration when we are doing our assessments? If we do want to be introducing something like transitional foods, we certainly need to be somehow assessing the appropriateness of those transitional foods. And I think ultimately what this means is that we're looking at person-centered and person-directed care. So again, it's moving away from that formulaic approach. If I see this, I'm going to do this. And really consider what are their food preferences? What is it that they miss? What is it their goal to eat? And can something like a transitional food fill that gap in there? So here are just some suggestions. We did include this in the handout that we uploaded for you all on a few different steps of how to implement transitional state foods into clinical practice. And so step 1 is that food trial. So transitional food samples need to be added to swallowing assessments in these different settings. And so looking at the clinical swallowing evaluation, so assessing permissibility in food trials, looking at instrumental examinations, so assessing bolus transport, assessing residue of these products. So it's not just about safety, it's also certainly about swallowing efficiency as well. Step 2, can these transitional foods actually be added to our texture recommendations? So as we're assessing those individual patients, and I know I've said the word individual many times, but again, this is an individualized process. We want to determine if that specific patient can have transitional foods added to their texture recommendations, based in part on individual post-processing manipulation and safety with the transitional texture. Step 3, start integrating it. So we want to review those recommendations with the dietitian, with the caregiver, implement those recommendations as part of their nutritional plan during main meals, snack time, social activities. So again, it doesn't have to be this focus on 3 meals a day. How can we implement this into small little bites throughout the day to really be boosting their nutrition and hopefully also boosting their quality of life by giving them more variety and giving them more options? The final step, and really I think step 3 and step 4, we presented them sequentially, but certainly can be done simultaneously, is thinking about the therapeutic benefit of transitional state foods. So we can use transitional foods in the rehabilitation of chewing or swallowing, as I mentioned before. We can use it to start to tax the system and work above the level of where a patient is currently at if we're talking about rehabilitation. We can also use it for developmental teaching as a first step in advancing to more challenging textures, or working on self-feeding ability and self-feeding techniques. So there's a lot of potential, not just for the diet itself and those diet recommendations, but also to be using it therapeutically and integrate it into our therapy sessions. So this is what we have for you all today. I know we left a few minutes for questions at the end. Here are both of our email addresses though, so please feel free to reach out to us if any questions come up after today or anything else you are curious about. I'll note on your handout that's posted or uploaded to the website, there's also a link to the Savory site. So if you're interested in trying some of the transitional foods, please feel free to reach out and request a sample of those to give it a try. You know, we always say, how can you give something to a patient until you try it yourself? So it's a great opportunity for you to give it a try. And now we will open the floor for any questions or comments or thoughts that you all have.
I have a question, so sorry. So can you talk a little bit, can you go into a little bit about the role of transitional foods in rehabilitating mastication? Because I think when I think of transitional foods, I think of, because they are so easy to break down, I'm a little curious of how the mastication element factors in.
Yeah, and I think a big piece of that there is that it's not necessarily going to be that challenging mastication of a hard food, of a sticky food, but even to just start getting that jaw moving and getting those teeth moving. And I think, you know, when you pick up a finger food, it doesn't really matter how soft it is when it's in your mouth, you see it as a solid. And so you're automatically going to start to try and chew it as soon as it enters the mouth. And so I think it's kind of that first step where, you know, you might be a little worried about putting something in someone's mouth and what they might do to it. You might be worried about their impulsivity, but can we at least start getting that jaw moving? Can we start getting those typical rotary masticatory patterns with a product that we really know they're not going to choke on?
That makes a lot of sense. Thank you so much.
Yeah. Any other questions or thoughts or comments? Okay, while you're all thinking, I'm going to put my moderator hat back on for a moment. So I am just going to let you know that this is now officially the end of the OSHA 2020 Fall Virtual Conference. So thank you all for your participation. I do want to make sure you're all aware, please look for an email after 5 p.m. today from pdconference.com with instructions for completing the conference survey. After you complete the survey, you can download your certificate of attendance. And if you have any questions about that or anything goes wrong, please feel free to reach out to the OSHA office for any needs. Otherwise, we are happy to stick around for a few more minutes if any other questions have come up. And if not, we wish you all a wonderful rest of your weekend, and thank you so much for attending.
Thank you.
I just wanted to ask, what did you say the contact was for, I mean, I know you said it's somewhere here, for trying to get some samples?
Yeah, what I could suggest for you is it's in the handout, and it's
Okay.
if you just go to savories.com, but also Ruth, if you just contacted me here, I'm just gonna put it here.
I've got your email address written down, I think.
Got it. Okay.
Yeah.
So just contact me there, and I will send you directly the link so that you can get in, and it's just a quick form fill and you get free samples.
Perfect.
So it's just an opportunity for you to try it in your mouth, like Samantha said, and just see how the dissolution happens.
Yeah.
It's an experiential learning, I think, with transitional foods that we really can't do on video calls, but it's really an important piece of talking about food.
Right. Okay. Thank you.
Yeah, you're welcome.